I'm Dr. Vaibhav.
5 minutes, sir. 5 minutes.
And my topic is strabismus surgery in internuclear ophthalmoplegia with exotropia. So, internuclear ophthalmoplegia present as a complex ocular motility problem as a result of medial longitudinal fasciculus damage. The surgical management of INO is challenging. Mainly the exotropia in the INO is difficult problem to treat. So, this case series elucidates the two cases with long-term INO with exotropia, one with unilateral INO and one with bilateral INO. So my first case is a 6-year-old female who presented with the complaints of outward deviation of the right eye and head turned towards the right eye, right side since the age of 2 years. And the patient is a known case of GDD and right-sided spastic hemiplegia since the age of 2 years. And the deviation of the eye and head turn develop at the age of 2 years, means with the episode of the spastic hemiplegia. So patient was responsive to the light, and she was having the refractive error in both eye, compound hypermetropic with the astigmatism. So you can see the head posture is turned towards the right side. The facial symmetry was normal, and on Hirschberg's test, there was 45-degree exodeviation with and without glasses. And on cover uncover, you can see there was a right eye divergent squint with alternate divergent squint. It's not much clear in the video, but in images you can see that in first image the child is fixing with the left eye and with exodeviation present in the right eye. And next image, the child is fixing with the right eye and exodeviation present in the left eye. On Leo version, there was adduction deficit in the right eye, and there was subtle adducting nystagmus seen in the left eye, and there was convergence insufficiency, and child was preferring the right side gaze. On prism bar reflex test, you can see that it was more than 45 prism diopter basin. Extraocular moments in right eye, there was adduction deficit about -2. So the final diagnosis in this case was right eye adduction deficit with left eye abducting nystagmus, which suggests you of the right-sided internuclear ophthalmoplegia. And patient is having the refractive error. So we planned the right eye lateral rectus recession 10 mm with medial rectus plication 8 mm under GA. So on post-op day 1, you can see there is only 15-degree residual exotropia. And on cover uncover, there was alternate divergent squint with good fixation. And on post-op day 14, it was about the same as post-op day 1. My next case is a 16-year-old male who presented with the right-sided head tilt and outward deviation of the right either eye since the age of 2 years. And the outward deviation of the eye was insidious in onset and it gradually progressing and present all the times, and there was no diurnal variation and in the severity of deviation. So you can see in the images it was the deviation, outward deviation was almost constant. Past history was little bit significant in this case. While doing the squint workup, child was advised the MRI, and we found that there was the child is having the Dandy Walker variant with supratentorial hydrocephalus and torticollis with shortening and thickening of the right side sternocleidomastoid.
So the head 30 seconds to conclude.
Yes,
30 seconds to conclude.
So you can see that there was 30-degree exodeviation present in and right over L. On dextro version, there was slight adduction deficit in the left eye and right eye showing the abducting nystagmus. And on Leo version, there was adduction deficit in the right eye and left eye showing the abducting nystagmus. and there was convergence insufficiency in this case.
Please conclude.
For this patient, we plan right eye lateral rectus recession 10 mm with half muscle inferior transposition. On post-op day 1, you can see that there was only 15-degree exotropia, and there was alternate divergent squint with good fixation. On post-op day 7, the convergence improved. So results. The primary position of XT was significantly corrected in both the cases with large lateral rectus recession and MR plication in the affected eye of the patient with unilateral INO and unilateral large lateral rectus recession with half muscle inferior transposition in one eye of the subject with bilateral INO
I think
with
we'll
improvement.
stop the presentation here because we don't have time, out of time. So the intention is that you have to present in 5 minutes. So your presentation should be, the number of slides and everything should be tailored for 5 minutes. And also, if you don't present in the time limit, then we can't even mark you. You lose marks. So then it becomes a futile effort, you know. So you have to, at your age, young age itself, you should put a habit of seeing what is the time limit and adhering to that time limit from your side. So you can give the same message in 2 minutes, in 5 minutes, in 50 minutes also. So you have to accommodate the time in your presentation.
Another thing is that while you are presenting the case, during the presentation itself, you can abridge your presentation. That much of laxity you should have. So the judges are telling you to conclude. It is better to conclude in the next few seconds itself. Okay, coming to your topic, did you mention among the symptoms, was there diplopia reported by any of the cases at any point of time?
No, sir. So the first case was is of GVD. So there was, this child can't tell anything. And in the second case, there was no diplopia.
Okay. And what was the management profile you had thought? I think in the surgical options, what you have mentioned is you have talked about medial rectus instead of resection. You had talked about plication. So, do you think a resection could have been a better option? What was the intent of using plication over resection?
Because to improve the medial rectus under action post surgery.
No, we have both these options available with us, no? Plication as well as resection.
Yes.
So, what is the advantage of one procedure over the other?
Sir,
That's fine. If you don't know, you
Okay.
just say you don't know, so you don't waste time. All right. Thank you, Weber. We have one more speaker, I think, in the audience. Dr. Afsana is here, right? Anybody else has come in since? Oh, okay. All the other presenters have come in. We'll go with Dr. Afsana because she came on time. So then we'll go back to you. So I hope, Dr. Afsana, you can manage to stay within 5 minutes. As doctor said, that if your time is coming up, then just conclude, right? So if you go over time, we don't ask questions or anything. We don't, all the other speakers have come up. So can we have last non-seeing child? Yeah, that's right. Yeah, please go ahead.
Good morning, everyone. Today's my topic of presentation is non-seeing child sensitization to MELAS in an emergency ophthalmology setup. I do not have any financial disclosure regarding the case. Before going to my actual case, I would like to briefly introduce about MELAS. MELAS is mitochondrial encephalomyopathy, lactic acidosis and stroke-like episode. It is a frequently maternally inherited mitochondrial disorder which affect multi-organs, mainly affect the tissues which have high metabolic activity. It is because of the mutation in MTTL1 gene with a single base pair mutation at the site of 3,2,4-thene adenine more than guanosine. So it will affect the mitochondrial respiratory chain function and oxidative phosphorylation, increasing the anaerobic glycolytic activities, thereby increasing the lactic acid and symptoms in the patient. So my patient profile, 1-year-old male child presented to pediatric neurology with abnormal body movement and fever since 2 weeks.
Some silence, please. Excuse me.
After the stabilization of the symptoms, the patient was referred to ophthalmology for poor eye contact. So he presented to us with poor eye contact, already undergoing treatment for abnormal body movement and fever. The developmental history was normal before the onset of symptoms. There was normal birth history, normal immunization history. Past history was also not significant. In the systemic findings, the child presented to pediatric neurology with the focal seizures which are involving the left side of the body, mainly the upper and the lower limb. In the central nervous system examination, the cranial sensory nervous system examination was within the normal limit. In the tone was variable on the left side, power was almost normal, reflexes were brisk, and plantar reflex was downgoing. Cardiovascular, respiratory, and per abdominal examination was without normal limit. Upon the investigation, CSF tap was found to be acellular, and venous blood gas analysis suggestive of lactic acidosis. It was raised. On MRI brain suggestive of encephalitis more than infarcts. So upon ophthalmologic evaluation, we found the child was not fixing to light, pupils were normal size and normally reacting, extraocular movements were also full, and anterior segment examination was within normal limit. Posterior segment examination revealed pigmentary changes at the posterior pole, which are observed in 40 to 50% of the MELAS patient. So with a triad of clinical presentation of encephalitis, stroke-like episodes, and lactic acidosis, along with our finding, that is ophthalmic pigmentary retinopathy, the diagnosis of MELAS confirmed later with genetic testing, which was positive for MTTL1 gene. So which it is also seen from the Paediatric Neonatology review article that the ophthalmic manifestations were the second most common manifestations in MELAS syndrome that can present as ptosis in the various forms. So for a pediatric ophthalmologist, non-seeing children is a diagnostic puzzle. But if we are aware of these findings in the MELAS, it will help the pediatric ophthalmologist and neurologist in clinching the diagnosis and starting appropriate management. So my take-home message is this: early ophthalmic evaluation is a valuable diagnostic tool. The macular pigmentation and other retinal findings should not be overlooked, and raising awareness among the ophthalmologist and neurologist is crucial for comprehensive patient care. Thank you.
Thank you, Dr. Asana. But you said that early diagnosis is because you can take future care, but is there any treatment for MELAS?
Ma'am, the treatment is only supportive. If the child is presenting with ophthalmic manifestation, we have to treat only its systemic manifestations. But in the systemic manifestation, we usually ignore like ophthalmic manifestations. So it does not help in managing the patient, but if it help in diagnosis only.
What supportive care can be given to children with MELAS?
Ma'am, it can affect the multi-organs. So if a patient presented with seizures, so we have to give from the pediatric neurology side, anticonvulsants. Arginine, L-carnitine therapies are given to improve the circulation of the brain so that the manifestations of stroke decrease and thereby decreasing the brain injury. Because usually these patients present with retrochiasmal vision loss and cortical blindness. So we can do nothing for them. The disease is fatal and the child usually die by the age of 14 to 15 years.
Okay. All right. Thank you.
Thank you.
Thank you. So we have, I'm guessing Dr. Aditya is not here yet, right? Dr. Himanshu is also not there. Dr. Prabhas, Dr. Anuradha is here. Dr. Anirudh Sharma. No. Dr. Meenal is here. Please come. Anybody else is here? As in, no, I know you're here, but what are your names? Okay. Shubhangi and Soumya Shri. Okay, all right. Please come. Yeah. So we have Dr. Meenal Patil. Ready, Meenal?
Yes. So, good morning all. Today I will be presenting a review about amblyopia, the pathophysiology of amblyopia.
You can just raise the mic.
Okay.
Good.
As we all know, it's the commonest visual disability affecting the pediatric population. The definition of it's not.
Slides are not moving. Go to next slide, please.
Yeah. So, as we all know, amblyopia has been defined as unilateral or bilateral decrease in visual acuity, which is due to either form deprivation or abnormal binocular interactions. When we say a form deprivation, it could be because of the significant refractive error, or it could be because of presence of media opacities like congenital cataract. And the abnormal binocular interaction happens in patients with anisometropia and strabismus. Amblyopia can happen because of combination of form deprivation and also abnormal binocular interaction. So when we look into the pathophysiology of amblyopia, the key features of amblyopia are there are no organic cause found on physical eye examination, and it is reversible condition if in selected cases if treated early, especially before the critical period of time. So are we actually sure there are no structural changes in amblyopia? We are going to review in this presentation. We are going to focus on anisometropic and strabismic amblyopias only. So what will be our areas of interest? We are going to look into the retina and the neuronal pathway. The functional analysis of retina can be done by electroretinography and visual evoked potential, which will give us the electrical activity happening in the retina and up to the cortex, that will be told by visual evoked potential. The structural evaluation of retina can be done by optical coherence tomography, and the newer advances is optical coherence tomography angiography, which will give us the vessel density in amblyopic eyes. Coming on to neuronal pathways, the functional analysis of neuronal pathways can be done by task-based MRI or resting state functional MRI. So what do you mean by functional MRI? They give us the actual neuronal activity happening in brain. Task-based means when a patient is looking at something or if he is hearing something. Resting state is when he is just lying down on the MRI machine. Structural changes, as we know, we can see on structural MRI. Coming on to electroretinography. Electroretinogram is nothing but the measure of electrical activity happening in photoreceptors, glial cells, bipolar cells, and ganglion cells. Multifocal ERG gives us the photoreceptor, bipolar, and glial cell activity, and the pattern ERG gives us the ganglion cell activity. Previous studies have shown there is decreased amplitude in amblyopic eyes, especially in the central ring. So we can see here amblyopic eyes have a lesser amplitude on multifocal ERG, which correlates with the severity of amblyopia, and there is no difference between the anisometropic and strabismic amblyopia. Pattern ERG also has shown a decreased amplitude in amblyopic eyes. Coming on to visual evoked potential, there is prolonged latency in amblyopic patients, especially in the central area, which correlated with the severity of amblyopia, and there is no difference between anisometropic and strabismic amblyopia. Optical coherence tomography gives us a high resolution cross-sectional image of retina, which distinguishes the layers of retina, giving us the insight about the structural changes in them. When the retinal nerve fiber evaluation was done in amblyopic patient, it was a variable result, but the macular thickness and choroidal thickness was higher in amblyopes, especially the anisometropic amblyopes. One point we should note is there is the macular thickness reduces to fellow eye level after the amblyopia treatment, that means after the occlusion therapy. Coming on to angiography, as I said, it will give us the superficial and deep vessel density. The previous studies have shown a variable result, varied from higher vessel density to lower vessel density. Our study, in-house study we have done, it's a pilot study. It has shown a significant reduction in vessel density, especially in anisometropic amblyopes and to some extent in strabismic amblyopes. So now we come to the neuronal pathway changes in amblyopia. As we all know, animal studies have done in which they have closed the eye for extended period of time, and it has shown a significant change in lateral geniculate body and striate cortex. So they have guided us in pathophysiology of amblyopia. But now with the newer advances of functional MRI, we can actually see the brain activity. So this image summarizes the neuronal changes in amblyopia. As you can see, there are gray matter and white matter reduction integrity. That means there is decrease in myelination, decrease in fiber organization, and white matter pathways. There is reduced response in functional MRI also. So we can now definitely conclude that there are retinal as well as neuronal changes, functional changes in amblyopia. Neuronal effect could be consequences of retinal inputs. However, we need to consider the possibility of variability in various types of amblyopia.
Can you conclude? No, please, because the time is
Even
over.
if the newer imaging modalities have enabled us to study the retina and central nervous system, prospective studies are must to understand the pathophysiology, which will help us in modulating the treatment strategies in
Madam, time
amblyopia.
is over. So,
Yeah, okay.
I mean, it's either you're not respecting us sitting here or you're not able to hear. So, please respect the time, everyone. When it's over, it's over.
Yeah, thank you.
So, I just had a point. Of course, I'm not sure where the gap is, but this is not a free paper. So, this is, it's a review.
Yes,
So-
ma'am, it's a review article.
Yeah, so is it, I mean, I can't fault you for that because the committee that selected it should not have selected it. The session is for free papers. So we can't evaluate this because it's not a free paper, so I'm sorry about that.
Yeah.
So we can't evaluate this
Yeah,
because
obviously.
it's not a free paper. So,
I
thank
think the
you.
selection
Thank
has
you.
been-
Yeah, it could have been in one of the sessions actually, should have been in a session actually.
I don't know.
Yeah. It should not have been submitted as a free paper.
Okay.
It should have been submitted as a talk.
Faculty talk.
Yeah.
Okay.
But it's a committee should not have accepted it, so that's our bad.
It's okay, ma'am.
Thank you.
Thank you so much.
So,
We can move on to the next.
yeah.
Dr. Harshvardhan is here. So,
Good morning. I'm presenting a case that is presented with ball-eyed bilateral internuclear ophthalmoplegia after mild traumatic brain injury.
Please stick to the time.
No
sir.
financial disclosures.
Yeah. Please stick to the time.
Yeah, ball-eyed bilateral internuclear ophthalmoplegia. It's a rare neuroophthalmological disorder which is characterized by bilateral exotropian primary gaze, bilateral internuclear ophthalmoplegia, impaired convergence, and can be associated with vertical gaze palsies, upbeat nystagmus, and skew deviation. So this is a case of 7-year-old female child with a history of mild head trauma subsequent to a post-epileptic fall, which is followed by unconsciousness for 15 days. Past history, she is a known case of hypoxic ischemic encephalopathy, seizure disorder, and intellectual disability. She had a normal ocular alignment and motility pre-trauma as documented by the photographs and the videos which were obtained from the parents of the child. Coming to the examination, patient was conscious but disoriented and uncooperative to the examination. On systemic examination, the CNS, there were signs of intellectual regression, that is inability to respond to the coherent commands, as well as severe weakness, which is associated with inability to perform the gross and fine motor weakness. She was unable to maintain the neck hold. There was bilateral exotropia present and bilateral convergence failure, and also in addition there was left eye ptosis. Vision she was not able to tell, but yeah, she was following to the lights. Pupils were 5 mm in the right eye, 4 mm in the left eye, and isochoria was present and it was sluggishly reacting. The lens was clear, both eyes. The rest anterior segment was within normal limit. Right eye fundus examination, there was temporal disc pallor, and in the left eye it was a complete disc pallor, and the rest periphery was normal. Investigations, MRI brain with MRI time of flight and venography. It showed a large intracranial bleed in the left parieto-temporal region, a decompensated communicating hydrocephalus, and foci of signal alteration in the midbrains and bilateral thalami, which is suggestive of subacute to chronic lacunar infarcts. The EEG done showed presence of multifocal sharp waves with absent sleep markers, which was suggestive of diffuse encephalopathy of non-specific cause. This is the MRI. This is showing, especially in this one, foci of blooming on SWI sequence, which is suggestive of the intracranial bleed, and also foci of signal alteration in the midbrain and bilateral thalami here, which is suggestive of subacute to chronic lacunar infarcts. So a diagnosis of Webinar syndrome with severe locomotor and neurological deficit secondary to mild traumatic brain injury was formed. On follow-up, the mainstay of management was observation along with symptomatic rehabilitation. And on follow-up, the convergence has been improved. The eye has been slightly coming to the primary position. Coming to the discussion, it is Webinar syndrome. It is characterized by bilateral medial longitudinal fasciculus damage with bilateral INO. The most common etiology being the infarctions of the midbrain in the older patients and the demyelinating disease in younger patients. And other associated etiologies can be traumatic, neoplastic, infective, etc. Thank you.
So what was unusual or rare about your case?
We can't be very sure that intracranial bleed exactly at that time trauma was responsible for INO, because the infarcts in the bilateral thalami, they are subacute to chronic, so we can't say that it is just because of the trauma itself. It may be because she has been a case of seizure disorder. It might have triggered it, we can say that, but we can't be sure that it is because per se of the trauma itself.
Is there any way that you can prove what is the etiology for your case, in your case? So in other words, that are there case reports of similar trauma leading to the start of Webinar syndrome?
We can exclude the other causes most probably.
Okay.
We can go ahead with excluding, for example, excluding the demyelinating causes or the infective causes. We can narrow down our etiology possible.
Okay.
Okay, thank you.
All right.
Thank you.
Usually the audience don't ask questions, but if you like, you can ask because we have some time.
If you have, we have time, so
Yeah.
if you have some point to make or any.
A long-term outcome.
So long-term outcome actually did. It was not done actually. The patient, after sustaining the mild trauma, after undergoing a conservative treatment, she actually had a bout of fever, etc. She had to get admitted. So the rest follow-up and other investigations were not done. And so it also depends upon the etiology. For example, if demyelinating, it has been reported that like 20 to 40% there can be a spontaneous resolution, especially it's a remission type of MS. And in infective, if the infection or the cause of infection is controlled, it can be corrected. In neoplastic, it has been shown that it is not so much, the spontaneous recovery is not so much possible in the neoplastic one. This is the one that I have actually studied or seen, not the post-traumatic. She has been improving. The bilateral exotropia has been improved. She has been fixating. The convergence has been improved. And rest follow-up is yet to be done.
We'll go to the next.
I think we can
All
go
right.
Thank you, sir.
Thank you.
ma'am.
Thank you.
Dr. Soumya Shri, is she with us? Okay, so you are presenting a paper on intracranial hypertension secondary to subserosal fibroid.
Yes.
Is that so?
Good morning everyone. I am going to present a case of idiopathic intracranial hypertension secondary to subserosal fibroid. So my patient, 47 years old female from Ganjam, Odisha, came with a complaint of blurring of vision in both eyes with frontal headache since 2 months. She had a history of intermittent syncopal attack and menorrhagia for 3 months. On general examination, there was extensive pallor and mild to moderate pedal edema. BMI was 32.5 kg per meter square. Then the patient was referred to physician and gynecologist and was diagnosed with having anemia with dysfunctional uterine bleeding. Then she was advised with some laboratory investigation and ultrasound abdomen. On ophthalmological examination, best corrected visual acuity was 612 parts in the right eye and 6/9 in left eye. Other anterior segment findings were within normal limit. On fundus examination, both eye, it showed papilledema with multiple hemorrhages and rod spot. Humphrey's visual field analysis 24-2 of both the eyes showed enlarged blind spot. OCT RNFL of both the eyes showed severe disc edema with 360-degree RNFL edema. Contrast enhanced MRI brain and orbit T2 Vetters axial scan showed flattening of the posterior sclera with dilated perioptic space and enlarged optic nerve sheath diameter. On T1 weighted sagittal scan, it showed partial empty sella, which was suggestive of raised intracranial pressure. MR venogram with contrast was showing hypoplastic right transverse sinus. Hemoglobin was 4.6 gram percentage. Peripheral smear showed microcytic hypochromic anemia. CSF opening pressure was high, that is 300 mm of water. Ultrasound abdomen and pelvis showed large subserosal fibroid. So based on the clinical examination, lab investigation and radiological examination, we came to a final diagnosis of idiopathic intracranial hypertension secondary to anemia due to menorrhagia caused by subserosal fibroid with anemic retinopathy. She was managed with 3 units of blood transfusion, then she underwent hysterectomy, and along with she was given oral iron supplements and carbonic anhydrase inhibitors. At 1 month of follow-up, she was symptomatically better and her hemoglobin was raised to 11 gram percentage. So idiopathic intracranial hypertension is mainly a syndrome of elevated intracranial pressure without any identifiable brain pathology and with normal CSF composition. Subserosal fibroid causing iron deficiency anemia has a rare association with idiopathic intracranial hypertension. Various types of anemia like hemolytic, iron deficiency anemia and aplastic anemia is associated with idiopathic intracranial hypertension. Anemia induces changes in the hemodynamics which ultimately will lead to raised ICP. So iron is considered as a regulator of thrombopoiesis which inhibits the rise of the platelet count and it prevents the hypercoagulable state. So the clinical features of iron deficiency are like headache, postural dizziness, syncopal episode, nausea, vomiting and exertional dyspnea. So anemia will cause hypercoagulable state which mainly causes arterial and venous thrombosis and leads to abnormal blood flow pattern and reduced deformability and increased viscosity of the blood cell. There is also reactive thrombocytosis which causes increased venous pressure and decreased rate of absorption of CSF. This all will ultimately leads to raised intracranial pressure. So in my case, there is presence of idiopathic intracranial hypertension with iron deficiency anemia is rare. Presence of subserosal fibroid causing iron deficiency anemia and IIH is extremely rare. So the role of ophthalmologist in meticulous history taking, thorough systemic evaluation along with ophthalmological examination is very important to arrive at a diagnosis, which signifies evaluate the patient as a whole, not the eyes only. So my take-home message will be, clinicians should be aware of the iron deficiency anemia as a rare but important association in patients with idiopathic intracranial hypertension. So the workup of the patient with raised ICP sign should include full blood count, appropriate hematinics, include iron studies, especially in the patient where there is no other risk factor for IIH. So a thorough systemic evaluation and proper lab investigation helped us as arriving at the correct diagnosis. These are my references. Thank you.
Thank you, Dr. Swami Shri, for sticking to time. Do you think there could have been any other reason? Because severe anemia leading to intracranial hypertension, that is rather a far-fetched association.
Sir, actually, anemia is a risk factor which can be associated with IIH. It's not a cause which will cause IIH. Like, it's a risk factor.
No, because severe anemia is something which is very commonly seen in the society.
Yes, sir.
And we don't come across intracranial hypertension directly associated with it.
Yes, sir. Sir, it's a risk factor.
So you can have so many risk factors. There could have been any other association which you might have missed.
Sir, actually, the patient presented with pallor and pedal edema and breathlessness, all these things. So then we did ophthalmological examination. There was papilledema with multiple hemorrhages and rod spots. So we suspected there is anemic retinopathy with papilledema.
So
then we sent for that gynecological evaluation. So there it was diagnosed as subserosal fibroid.
So there was a reversal of symptoms by simply transfusing blood.
Yes, sir. By blood transfusion, then the hemoglobin was increased to 8 and 8. Then she underwent hysterectomy and was given oral iron supplements and carbonic anhydrase inhibitor, where her symptoms was relieved. And at 1 month follow-up, hemoglobin was raised, and she was symptomatically better.
Okay.
Maybe you could change the one is that why would you call it IIH?
Ma'am, because anemia is not a cause for intracranial hypertension. Ma'am, it's a association, like it's a risk factor for this thing. It's not directly causing this thing.
I mean, you have an etiology, so it's not idiopathic. So either one of the two is correct. Either it's idiopathic, or you're attributing anemia as a cause to it.
Yes, ma'am. Like anemia was a risk factor for causing this thing, because she was coming in that category of IAH. She was obese. She was in a reproductive age. She was young, and there was no other.
So maybe it was a chance association. Maybe it was a chance association.
Yes, sir. So because MRI features were also suggestive of IAH.
Okay.
Yes, ma'am.
So maybe it's an association.
Yes, ma'am.
It may not be. So the title, when you're saying secondary to, so I think it's in a case of, chronic anemia would be better, more appropriate, because you're not able to prove that it's secondary to that. So it's a.
Ma'am, like subserosal fibroid mainly caused TUB, and there was anemia for that thing.
Okay. All right. Thank you. Dr. Shubhangi is here, right? So Dr. Shubhangi is next with her paper. Any other speakers are here? What's your name, doctor? Anirudh. And any other speakers here? Okay.
Good morning all. Today I shall be presenting the clinico-demographic and etiological profiles in acquired esotropia, a prospective study. I have no financial interest to disclose. The primary objective is to study the clinico-demographic profiles in patients with acquired esotropia, to report the varied etiologies, and to determine the functional outcomes in this subset of patients. Acquired esotropia can be acute or chronic in onset with variable progression. The prevalence of acute esotropia is 10.4% of the total diagnosed esotropia cases. It can be comitant or incomitant. In the comitant variety, acute acquired comitant esotropia is characterized by an acute onset of esotropia with an equal angle of deviation in all fields of cases. As per Burien-Miller classification, there are 7 types. In concomitant variety, esotropia with varied angles of deviations in different cases. Acute esotropia can have variable etiologies. The study was a prospective study conducted at the Department of Ophthalmology at KIMS Bhubaneswar with a sample size of 21. Detailed ocular and systemic evaluation of all the patients was done, and ocular and laboratory investigations along with neurological imaging was done wherever applicable. The inclusion criteria took diagnosed cases of acquired esotropia with an age range of 5 to 55 years and excluded severely ill or patients who were admitted in ICU. It also excluded infantile esotropia cases and also patients with history of previous ocular surgeries. The patients were followed up at 1st, 2nd, 3rd and 6 months. Statistical analysis done gave us a p-value less than of 0.05, which was considered as statistically significant. On coming to demographic parameters, the mean age was 32.3 plus minus 0.36 years. There was a male preponderance in our study participants. Most common presentation was bilateral. On best corrected visual acuity, from presentation to follow-up of 3 and 6 months, there was a significant improvement in vision from 0.5 to 0.2. Coming to etiologies, neoplastic origins were most common, followed by post-fever and ischemic. On lab investigations, D-range serum homocysteine, lipid profile, ESR and HbA1c was found in ischemic patients, and in idiopathic intracranial hypertension patients, there was decreased serum iron and ferritin levels. On OCT, 43% of patients had RNFL thinning, whereas 36% of the patients had RNFL edema and thickening. CSF analysis revealed 20% cases with viral meningitis, and CSF study with malignant cells was found in 26% of the cases. We did neuroimaging, which is MRI brain and orbit with contrast, and along with MR venogram with contrast wherever applicable, and which revealed a finding of raised intracranial pressure as the most common, followed by hyperintensity and enhanced lesion in 24.6% of the patients. On HFA, advanced field loss was the most common finding, followed by enlarged blind spot and inferior quadrant tonopia. Due to poor vision, 26% of the patients' vision field could not be obtained. Coming to discussion, the study conducted by Clark and Nelson reported acquired esotropia secondary to refractive errors, decompensated esophoria, and prolonged neowork. The study by Buchwinding Lee et al. Revealed intracranial disease such as elevated intracranial pressure, tumors like glioma, anal-Chiari malformation, and cerebellar and thalamic tumors could be major etiologies. In study by Liu et al., in 30 children with acquired esotropia, 12 had comitant esotropia, while the rest 18 had incomitant esotropia. In our current present study, neoplastic origins were revealed to be most common, followed by infective and ischemic patients. So the take clinic message from this presentation is that majority of the patients present with acquired esotropia have neoplasia as a major cause. Patients with refractive accommodative esotropia are orthophoric at final follow-up. A detailed history, clinico-radiological evaluation along with appropriate lab diagnosis helps in clinching the appropriate diagnosis in the final follow-up. These are my references. Thank you.
Thank you, Dr. Suvangi. One question. You talked about neoplasia as a major cause for these esotropias.
Yes.
Now, were there any frontal tumors also reported in your neoplastic lesions?
Yes, sir.
Okay. So, do you think that the frontal tumors are frequently associated with raised intracranial tension?
Yes, sir. Tumors like meningioma frequently have raised intracranial pressure.
Because the size and the site of the tumors both are equally important.
Yes.
And when you talk about the site, the frontal tumors are generally not so frequently associated unless the size is very big. So I think the main cause in this scenario would have been the raised, all those tumors causing a raised intracranial tension. That would have been more appropriate.
So, Dr. Shubhangi, I just missed that. How many, what was your study period and how many cases did you get?
The study sample size was 21 patients and the patients were follow-up at 1, 2, 3 and 6 months.
So, you mean sample size, you calculated the sample size, or you mean the number of patients you included were 21?
The number of patients at the final count was 21 now.
All right, good.
Thank you.
So I think we have just one speaker left with us. All right.
Dr. Anirudh, right? Dr. Anirudh Sharma. Who's anybody else? Okay, Dr. Anirudh Sharma, please.
Dr. Anirudh here. So you'll be talking about an interesting case of acute acquired comitant esotropia and bilateral idiopathic optic neuritis.
Yes.
Is that right?
Yes.
Again, Dr. Anirudh, you have 5 minutes for your presentation. Please don't go over time. I will stop you if you go over time.
Good morning, everyone. Today I'm going to present an interesting case of acute acquired comitant esotropia with bilateral idiopathic optic neuritis. Acute acquired comitant esotropia is a type of non-accommodative esotropia which usually present in the older children and young adolescents which have previously straight eyes, but it is of acute onset in duration. It is often associated with diplopia. It has been classified in 5 types. First is Swan type, which occurs after a period of interrupted binocularity. Second is Berrien-Franchetti type, which has minimal hypermetropia and diplopia, often associated with physical or psychological stress. Third is Bialchowski type, which is seen in patients with myopia and convergence spasm. Fourth is refractive type, which is due to any uncorrected refractive error which is present in the patient already. And fifth is any intracranial pathology, which is a lesser common entity and it is most commonly associated with posterior cranial fossa lesion. So, purpose of this case was to highlight the importance of going through proper neurological assessment before diagnosing any case of acute acquired comitant esotropia, and particularly with CE-MRI and multidisciplinary approach. Coming to the case presentation, there was a 9-year-old male child which presented to the AIIMS Rishikesh OPD with acute onset inward deviation of right eye for 6 months, which was associated with diplopia and diminution of vision, and this history was given by her mother. And there was no significant history of any near work or excessive screen usage, no history of any occlusion therapy or uncorrected refractive error. Birth history was well within normal limits. At the clinical presentation, the deranged profile were color vision and contrast sensitivity, which were color vision were deranged and contrast sensitivity was decreased to 1.65, and pupils were pupillary reaction was ill sustained. Coming to the orthoptic workup, Hirschberg test were right eye 30-degree esotropia with on cover test, left eye, on covering the left eye, right eye was taking the central fixation, and on uncovering left eye was maintaining the central fixation. And on alternate cover test, there was alternate fixation present. On stereo acuity test, there was 200 seconds of arc was present, and diplopia was present on WAT4 dot test. AC by A ratio was 3:1. Retinoscopy acceptance and fundus examination was well within normal limits. This was the pre-op 9-gauge photo of the patient showing right eye esotropia. CMRI brain plus orbit was done for the patient, which revealed that bilateral optic nerve tortuosity was present in the intraorbital segment. And then child was referred to pediatric neurologist for further follow-up, where he had undergone various neurological assessment to rule out any other associated intracranial pathology. VEP was done, which showed prolonged P100 latency in both sides, right more than left. As CSF analysis was done to rule out any infectious or autoimmune status, and a diagnosis of acute acquired comitant esotropia with bilateral idiopathic optic neuritis was made, and child was given methylprednisolone pulse therapy for 5 days. That was 750 mg in 100 ml NS over 1 hour, and tablet acetazolamide 250 mg, and then child was discharged on the tapering dose of oral prednisolone. And this was the post-IVMP ocular examination, which revealed that contrast vision was normal and color vision was normal, and contrast vision was improved to 1.89, which was previously 1.65. And VEP was also improved, but although it was prolonged, but it had improved from the previous reading, which was 130 previously and 110 in the current reading. This was the post-op 9-gauge photo. After 4 months, for which squint surgery was done, bilateral MR recession with bilateral IO recession after pediatric neurologist clearance, and there was no residual diplopia, and the child was asymptomatic. So, coming on to the discussion, this underscores the critical role of imaging, particularly CEMRI, in evaluation of the patient with acute acquired comitant esotropia, especially when the etiology is unclear. And such cases often necessitate a multidisciplinary approach requiring neurosurgeon, neurologist, pediatric neurologist involvement for the optimal comprehensive management and patient outcome. And coming on to the conclusion, our experience differs from that of many other centers where Arnold-Chiari malformation and other intracranial pathologies were mainly involved. In this case, we observed optic neuritis as the leading cause of this pathology.
Okay, thank you.
So, what was interesting about your case?
So, at our center, it usually presented with other intracranial pathologies previously, like as astrocytoma or Arnold-Chiari malformation. But in this case, the optic neuritis was involved, and before taking a patient for the OT, we had to rule out any associate, because there was no clear etiology to rule out any a cause for the acute acquired comitant esotropia. So we went to the through CEMRI to rule out any neurological involvement, and we found out that there was bilateral intracranial optic nerve tortuosity with thickening of the segment.
Was there any change in the visual status after your strabismic surgery?
So visual status was previously 6 parts on Islanden, and after the surgery was also same, but on contrast sensitivity has increased, and color vision was also improved for the patient.
So in the
and the child was previously prescribed refractive glasses, so child was doing fine with the vision.
at your center, do you how frequently do you send for CE MRI? Only if the diagnosis is not certain?
So usually, if the diagnosis is not certain, but we are thinking that we should go through neurological assessment before diagnosing any case.
Any case of secondary, any case which is secondary, usually you do ask for imaging for these cases. It may not be a CE MRI, but definitely ask for imaging.
Imaging to rule out any other pathology involved which is leading to the concomitant esotropia.
Would you not do, so I don't understand. So standard practice is to do imaging, right, for these
Yes,
cases which are secondary. So it is not because you don't have a primary pathology,
Yes,
not
ma'am.
congenital. You have it, it's started as a new condition. You will get imaging done.
Yes, ma'am.
So that is already highlighted. It's a protocol. Anyway,
Excuse
that's
me,
fine. I get
excuse
your
me,
point.
ma'am.
Yeah.
I just wanted to add to this case.
Sure.
Have you done the refraction in this patient?
Yes, ma'am.
Then atropine refraction?
Yes, ma'am. Cycloplegic refraction was done.
Okay, sometimes actually the cycloplegic refraction is not adequate. So to rule out the refractive accommodative esotropia component, you have to do the atropine refraction. Because that acute esotropia could be because of this RAET, and you have to wait for the patient wearing the glasses with good compliance till at least 2 to 3 months before coming at a conclusion that it is not because of the RAET.
Okay. Thank you.
Thank you.
you, Anirudh.
Thank you.
Okay, so I think we have
Any other presenters are remaining here?
Dr. Aditya Gautam. Is he with us? No. And Dr. Himanshu Prakash? Not there. Dr. Prabhash Shekhar Mishra? It's not there. Dr. Anuradha?
It's a roll call
Then
attendance.
Dr. Zubair and Dr. Deepti Gangwar. Okay, so with that I think we can come to the end of the session. Any concluding remarks?
Thank you very much to all the bright youngsters who presented and all their friends who stayed back in the room for them. So well presented. Even our faculty talk was also good. So although it's not a free paper, but we enjoyed listening to your talk. Thank you, everyone. I think two important points. One is that although everybody took a lot of effort to make their slides, but only some of you took the effort to make sure it stays on time. So you have to, I enjoyed the first presentation which showed all the clinical signs with very good videos. I think he left, but it took too much time. So the messages are try to stick to time as you go to the other sessions in AIOS, and we hope you keep presenting your papers, your work. Try not to take cases, but instead, like for example, the last presenter, you could have put together all the cases where CMRI was done in their practice. So try to present, whoever's presented cases, try to present papers, like a series of cases or something like that. Thank you.
Another last point which I would like to add is that the discussion part should at least have about 30% of the time, because sometimes you have only the clinical points which are being presented, and there is very little time left for the discussion. So because we are more interested in the discussion and what is the originality of the paper. So I think you will do well if you include the discussion part in better light.
Thank you.
Okay.
Thank you, everyone.